කියලා තියෙනවද කවුරු හරි? නැද්ද? හවුද?
නෑ සර්.
නෑනේ. Buhover syndrome කියන්නේ it's a transmural esophageal rupture because of usually it happens because of raised intramural pressure. You can esophagus actually when the pressure rises, the esophagus can rupture. So if for the for the pressure inside the esophagus to rise, what should happen? දෙපැත්තෙන් මේ වහෙන්න පයිනේ. දෙපැත්තෙන් connect වෙන්නේ කොහටද? Close. In the lower end it's connected to the stomach නේ. upper end එකේ glottis එක ගන්න යන්නේ මේ esophagus එකේ. මේ glottis කියලා ලියනවා. upper end එකේ තියෙන pharynx එක ගන්නනේ. drunk. upper end එක is connected to the oropharynx. lower end එක තියෙන stomach එකට. So for some reason if the pylorus පල්ලෙහා තියෙන pylorus එක උඩ තියෙන prepopharyngeal muscle එක for some reason if both are closed with it usually happens with uncoordinated vomiting. So if when there's vomiting either one should open, isn't it? So with uncoordinated vomiting if the prepopharyngeal muscle and the pylorus is closed, there can be sudden rise in the transmural esophageal pressure, and because of that the esophagus can rupture. So usually it occurs with forceful vomiting. So typically young patient comes with this syndrome, and in addition to vomiting, this can be precipitated by some things like coughing, straining, or maybe during seizures or even during labor. So if there is esophageal rupture, how could we diagnose it? නිකන් හිතලා කියන්න බලන්න.
Vomiting, abdominal pain.
ඒ clinical features නේ. මේ ලියන්නේ කවුද? අයියෝ. පොඩිම බලන්න. imaging නේ ගොඩක් වෙලාවට අපි දැන් ඕන එකක් CT can be used, so you can use the X-ray, but the problem with the X-rays, it can be even normally in about 30% of patients. Right? So in the X-ray, what could you say if you do X-ray in a patient with a esophageal rupture? What are the signs? What sort of things that you would be able to see in the X-ray? Connection එකක් තියෙන්න පානේ esophagus එකයි lung එක මේ mediastinum එක අතර එතකොට. or with the maybe lung or pleura. So the features are you can see a left-sided pleural effusion. Then other findings I can see hydropneumothorax, even mediastinum, or even some subcutaneous emphysema. Those are the features that you will be able to see in the X-ray. Right? So presentation-wise, Buhover syndrome is classically described with a triad. The triad is vomiting, chest pain, and subcutaneous emphysema. Right? If a young patient comes with repeated bouts of vomiting and complaints of chest pain, like this should be kept at the back of your mind, because if you miss esophageal rupture, the patient can die, isn't it? Alright? How can it differentiate this syndrome from a Mallory-Weiss tear? Mallory-Weiss tear එක මතකද? අපේ low esophagus එක තුවාලනවා ලේවමනි කරන එක. The patient will come with hematemesis නේ. But in case of Buhover syndrome, the patient will not have hematemesis. හරිනේ? So that's about Buhover syndrome. මේකට උත්තරේ මොකද්ද? So this one, A is the correct one. It is associated with rupture of the left posterior wall of the lower esophagus. My left posterior wall kata ugalanta onne. Just remember that it's something which is associated with rupture of the esophagus. Can you please tell the R triad again? The triad is vomiting, chest pain, and subcutaneous emphysema. I triad I කියන්නේ කවුද කියන කියලා තියෙනවා. Right? chest x-ray normally 60% about 30%. chest x-ray එක තියෙන ඒවා තමයි you can because ගොඩක් වෙලාවට left sided එකක් තමයි left sided full refusion එකෙන් පුළුවන්. Other findings are you can get pneumothorax, hydropneumothorax, pneumomediastinum and maybe subcutaneous emphysema. Right? chest x-ray normally 60 never 30. Classical presentation කිව්ව hematemesis is not seen in behaviors. ඒක ඉන්නේ මොකේද මැරිනි ස්ටේ එකක් තිබුණොත් නේ. හරිනේ? ඊළඟ මේක කවුද ඉන්නේ මේකට උත්තර කියන්න මං ගහන්නේ කො උත්තර කියන්නේ නැද්ද කවුරුත් කිය ඇහෙන්නේ නැද්ද හලෝ ඇහෙන්නේ නැද්ද නැත්නම් කියන්නේ නැද්ද ඒ
Sí.
කියන්නේ සී මේ කටින් කියන්නකෝ
Sí.
ඊ අනේ කවුරුරි අපේ මේ ගුප්පේ කට්ටිය නැද්ද කියන්නේ නැද්ද Hypotension should be managed with vasopressors as it is usually secondary to neurogenic shock. If a young patient comes, what are the causes of hypertension in that patient? In a trauma patient, say if a trauma patient comes to the ED or where ED hari hospital eකට hari district hospital eකට hari එනවා පොල් ගහින් අట్ల පොරක් එනවා කොන්ද කඩාගෙන. So what are the causes of hypertension in any trauma patient? First, like if you think about the DDs for hypertension,
Hemorrhagic shock.
hemorrhagic shock unless otherwise proven in a trauma patient, you must always assume that the patient is bleeding. If a patient comes with an acute, especially after acute spinal cord injury, the mechanism of trauma should be very significant, isn't it? So what are the causes that can lead to hemorrhagic shock? One thing is there should be external bleeding from a long bone, or if there's a wound, wherever it is, if there is ongoing bleeding, it will lead to hemorrhagic shock. What are the other potential causes of hypotension in a patient with spinal cord injury?
Spinal shock.
Spinal shock and neurogenic shock can come. It's one of the causes. Right? Nothing to anything anithya patient can have tension pneumothorax. Even very the cardiac tamponade. ඊට පස්සේ neurogenic shock එන්න පුළුවන්. The patient can have myocardial injury, myocardial contusion. ඕනියක් එන්න පුළුවන්. The patient can have intraabdominal bleeding. Patient can have pelvic fracture. Anything can happen. So in a trauma patient, if the patient is hypotensive, you must not assume that the patient is having neurogenic shock or spinal shock and then start on vasopressors. Of course, if the patient is having spinal shock, you should not overload the patient, and there should be a low threshold to start vasopressors. But still, you should first resuscitate with fluids and bring the blood pressure to a decent level, and then look for causes of bleeding. And if there is no obvious cause except for the spinal cord injury, then you can start vasopressors. So if you want to start vasopressors, what would you start? One then spinal shock එක්කෙනෙක්ට. මොනවද දෙන්නේ? මේ කතා කරන්නේ ඇහෙන්නේ නැද්ද? මම කියන්නේ
No adrenaline.
No adrenaline. Can you give dobutamine? Can you give adrenaline? Say you're in district hospital. A young patient comes after he falls from a tree. NORAD is not available. District general like in central line utna then transfer karanna one patient's hypotensive with a BP of 80/40 and heart rate is say 70. You don't have NORAD. What can you use? ඇත්තට එනේවන තියෙන ලංකාවේ මොනවද පුළුවන් ඇඩ්‍රිනලින් පුළුවන් හරි what else vasoconstrictors ephedrine saane you don't put infusions ne ephedrine has got alpha and beta effects both ne like for long term, short term management, you can use ephedrine and bolus the patient with ephedrine. What else can you use? NORAD OS, what can you use? And if there's a constrictors infusions metrominal like if the patient doesn't have central line, you can use the metrominal infusion, but the problem is it's not free available and vial is around 20,000 rupees. And if the but if the NORAD is not available, first line NORAD, Peter Hospital here. Succinylcholine should not be used as paralytic agent during rapid sequence intubation. Rapid sequence separate. Hello? Ax ගහන්න පුළුවන්ද? බටයක් දානවනේ.
පුළුවන්.
පුළුවන්. Patient එනවා දවස් 5කට පස්සේ.
Can cause severe hypokalemia 2-3 days later.
Cut off වෙලාව මේ කාලයක් දන්නවද?
2-3 days sir.
සාමාන්‍යයෙන් කියන්නේ 48 hours වගේ කියලානේ.
Yes sir, 2-3 days.
Patient කෙනෙක් ඉන්නවා, patient has come with a spinal cord injury and he's in the ward. So after say 4 months he gets aspirated and somebody decides to tube the patient with sucks. Can sucks be given?
No, given at any point.
මොකද?
Sucks can be given at any point.
නෑ සක්සාවන්නේ ගහන්නේ like various books tells various things. Usually before 48 hours it can be given, but after 48 hours to 1 year you should be cautious when giving sucks. Because in patients with special spinal cord injuries, the extrajunctional receptors get perforated. Because of that, when you give sucks, you can get life-threatening hyperkalemia and the patient can have a cardiac arrest. Because of that, sucks should be given with caution in a patient with a spinal cord injury. There is high quality evidence to support the early use of corticosteroids. Corticosteroids gahanna spinal cord injuries. Like they have done various trials and they have seen whether there is a mortality benefit, but there has been no clear mortality benefit, and with sucks the infection rate has gone up. So it's not with corticosteroids, it's not there is no high quality evidence to support the early use of corticosteroids because of that. Alright. An nasogastric tube should be inserted early during ED management. Why is that? Why do you use an NG tube? People think that an NG tube is used to prevent aspiration. If like having nothing is having an NG tube is better than having nothing, but an NG tube will not prevent aspiration. Why do you use an NG tube? Especially say this patient comes with a Karapiti ETU with GCS of 15. Why would we bother to put an NG tube? Venura කියම්මා වෙනුර ඉන්නනේ වෙනුරේ කටහඬ අහන්නත් ආස වෙනුර
Yes, sir. Paralytic ileus.
Good, very good. So in a patient with spinal cord injury, there can be acute gastric distension and paralytic ileus. Currently, the problem with if the patient develops gastric distension and paralytic ileus because of the abdominal distension, it can affect ventilation. Currently, early insertion of nasogastric tube should be done. In addition, early catheterization is also recommended because it prevents over distension of the bladder. හරිනේ මේ ප්‍රශ්න දෙකක් අහලා තියෙනවා මේ could you please explain the difference between spinal shock and neurogenic shock කියලා කවුරුහරි දන්නවද ඒක මේ ස්ලයිඩ් එක හදාගත්ත එකට මේක පේන්නේ මොකක්ද What can you see? I mean, neurogenic shock versus spinal shock කියලා පේනවද?
නෑ සර්.
දැන් පේනවද?
ඔව් සර්.
එක්කෙනෙක් message එකක් කියලා explain the difference between neurogenic shock and spinal shock කියලා. ඕක බලන්නද කොහොමද කියන්න බලන්න? Does somebody know the difference between spinal shock and neurogenic shock? So in the early phases of in a patient with spinal cord injury, there will be a distributive shock. Distributive shock කියන එක දන්නෝනේ. There will be vasodilation and there will be a relative hypovolemia. So there will be a shock. Right? So in a patient with spinal cord injury, if there is interruption of the autonomic pathways, it will lead to a distributive shock. Right? Autonomic pathways කියන්නේ there will be involvement of the sympathetic outflow. Sympathetic system will be responsible for vasoconstriction. If the sympathetic outflow is cut off acutely, there will be vasodilatation. Right? Then in addition, there are these fibers which innervate the cardiac muscle, especially between T2 to T5. And because of that, if there's an injury at those levels, there will be involvement of the cardiac sympathetic nerves, and it will cause decreased ionotropy as well, because the sympathetic nerves are responsible for the contraction of the heart, isn't it? I don't know. There is a spinal cord injury, especially above say T6, there is a risk that the cardiac sympathetic nerves will be affected. Then there can be bradycardia as well. I don't know. Sympathetic outflow කියනකොට parasympathetic predominant වෙනවා. heart එකේ හැමෝනේ sympathetic parasympathetic දෙකම තියෙනවානේ. So there will be increasing vagal tone as well. So all of these effects will lead to distributive shock. හරිද? spinal shock කියන්නේ මොකද්ද? Hello? කියන එක ඇහෙනවද? hello
Yes, sir.
spinal shock කියන්නේ මොකද්ද?
Damage to the tracts of the
ඔයගෙද ස්පයිනල් ෂොක් කියන්නේ පස්සේ දැන් මුලින්ම මේ then say assume that there is you call transection of the spinal cord at a certain level lumbar thoracic කියන්නේ. So because of that initially there won't be any impulses going below that level, isn't it? අර ඒක නිසා කවුද පන්නේ තියෙන්නේ ඒකනේ paraplegic වෙන්නේ සාමාන්‍යයෙන් ලොම්බෙක් ගියොත් එහෙම. Then what with time there will be connections developing between the upper part and the lower part. So with time there will be reflexes coming later on. The මුලින් තියන්නේ you have loss of reflexes below the level and you have flexidoreflexia. So because of that there will be hypotension and neurogenic shock. But after some time the reflex activity will return about after say 3 to 6 weeks. After that you get spasticity and then you get a phenomenon called autonomic dysreflexia. හරිද? ඒක තමයි පස්සේ දකින්න පුළුවන් එක. හරිනේ? So that's the difference between the two. In the ප්‍රශ්නයක් අහන what are the early and late complications of spinal cord injury? You දන්නවද? spinal cord injury පස්සේ දවසක් මේකම කර කර ඉන්න වෙනවා. ප්‍රශ්නයක් අහලා spinal මම complications මේ I'll tell later. I'll do a class later on. Is spinal shock cause hypertension කියන ප්‍රශ්නයක් අහලා තියෙනවා. Spinal shock එන්න පුළුවන්ද? Sorry, spinal shock එක hypertension එන්න පුළුවන්ද? Yes, it can. Spinal shock කියන්නේ the like neurogenic shock is a clinical feature of spinal shock. Spinal shock කියන්නේ because of the transection you get level the sign and symptoms below that level, and neurogenic shock is associated with spinal shock. මේ early and late complications spinal cord injury පස්සේ ගමුනේ. නැත්නම් වෙලා යනෝනේ. ඊට පස්සේ එක make a pain. So this is the next question. Spinal shock is characterized by which one of the following? Kiambala. Go.
C.
See. See, hypertension එන්න පුළුවන් spinal shock එකේ. ඕගලන්ට spinal cord injuries කවුරු හරි පිළිවෙලකට කියලා දෙයක් තියෙනවද මුලින්ද ළඟට? no ලුනේ. මේක එහෙනම් මේ it would be better පොඩ්ඩක් කියලා කරා නම් හරි කල්ල කරා නම් MCQ. එකන්ගේ මේ පාවිච්චි ඔයගොල්ලෝ. මේ theory part okay හරි Hurry. So what's the difference between spinal shock and neurogenic shock? Neurogenic shock කියන එක හරිනේ. So neurogenic shock is a kind of distributive shock which happens secondary to peripheral sympathetic denervation, especially at cervical and thoracic levels. Ne? හරිනේ. So in neurogenic shock you get hypotension, and if there is involvement of the heart you get bradycardia. ඒකත් හරිනේ. So in addition, in neurogenic shock you can get hypothermia because of the vasodilatation, and because of that there can be lots of heat from the body. හරිද? ඒක හරිනේ ඒක. Spinal neurogenic shock කියන්නේ clearද?
ඔව් සර්.
අනේ පොඩ්ඩක් කියන්න. මේ ප්‍රශ්න දෙඩබඩ ගාලා එන හොගාලා මේ ප්‍රශ්න ටික උත්තර කියන්න මේ කියලා. හරිනේ neurogenic shock. The spinal shock කියන්නේ මොකද්ද? If somebody asks what is spinal shock, how can you answer that? Hello? කිසිම නෑනේ. hello මන. මම කියන්නම් එන. So spinal shock is the condition where you get flexidity, or loss of muscle tone and loss of reflexes that occur immediately after spinal cord injury, and after a period of time you get spasticity. හරිනේ? So spinal shock is a term. හරිද? It's actually a physiological thing, not actually an anatomical thing. There is another definition. Spinal shock is a term which is described to use the state of transient physiological rather than anatomical loss or depression of spinal cord sensory and motor functions below the level of a complete or incomplete injury that occurs soon after the injury. So basically it's a loss of reflexes and the patient developing flexibility after injury. Sometimes it can be associated with neurogenic shock as well. The wording spinal shock is specifically used to describe the patient losing the reflexes and developing flaccid paralysis in acute situation. And in the long term, the patient redevelops, get exaggerated reflexes and develop spasticity. So out of these reasons, hypotension, hypovolemia and bradycardia is seen in neurogenic shock because of the involvement of the sympathetic nerves and because of the vagal predominance. And flaccid paralysis එන්නේ කීයද මේ spinal shock එකේ මුල අවස්ථාවේ පස්සේ එන්නේ spasticity. හරිනේ? එහෙනම් තා ප්‍රශ්නයක් අහනවා. How do you classify spinal cord injury? දන්නවද ඒක? Asia's classification කියලා එකක් දන්නවද?
Yes sir.
slide හදන්න කටින් තමයි කියන්න වෙන්නේ. So you classify spinal cord injury according to the AISA classification. AISA කියන්නේ American Spinal Injury Association එක. ASIA නේ. හරිනේ. මම ප්‍රශ්න ටිකක් තියෙන එකට මේ කටින් කියලා උත්තර ටික කියන්නම් පස්සේ. You classify spinal cord injury according to the AISA classification. If you Google, you can find it. ASIA. හරිනේ. American Spinal Injury Association. So depending on the AISA scale, there are 5 categories: complete, incomplete, normal කියලා. So you can go through the AISA classification. Nobody will ask to write the AISA classification. For MCQ, just know that AISA is the classification which is used to categorize the spinal cord injury. Then there is something called autonomic dysreflexia associated with spinal cord injuries. ඒක දන්නවද ඒක? You can't. Autonomic dysreflexia කියන එක සාමාන්‍ය you can't see in the acute situation. It develops after some time. Right? So it's a phenomenon where you get because of the massive sympathetic stimulation when you stimulate the patient below the spinal injury level. For example, say there is a patient with a thoracic spinal cord injury and he is paraplegic, and say you do some sort of manual like either PR or maybe catheterization, and because of the sudden stimulation there will be massive sympathetic surge. Because of that the patient will get hypertension and bradycardia. And so you don't bother much about the mechanism of developing this bradycardia. Because of the hypertension there will be inhibition of the cardiac vasomotor center, and because of that the patient will develop bradycardia. Right? Just know that autonomic dysreflexia is a phenomenon which can be seen in patients with spinal cord injury after some time, and then because of that there will be a massive sympathetic stimulation, and because of that the patient even can die. Right? So usually the patient gets this autonomic dysreflexia commonly due to mainly bladder and bowel distension, or maybe pressure source, or maybe any kind of intervention or stimulation below the level of the lesion. Right? So those are the main clinical aspects. Then you have to know a bit about the acute management of a patient with spinal cord injury. You assume that there's a patient comes after a fall from a tree to the therapy ETU. How would you manage that patient? Tagal giyan me tagain bayane mal ප්‍රශ්න ගොඩක් හදාගන්නවා දෙකක්වත් කරන්න මේක හිතලා කරලා හිටියොත් එහෙම.
Sir, we have to assess the patient and manage according to the ATLS protocol, and once the patient are stable we have to manage the specific problems. There is autonomic dysfunction, respiratory problems, abdominal problems, and bladder and bowel care.
Spinal cord injury suspect connection. If first thing is you should assume a spinal cord injury depending on the mechanism of injury. For example, if a patient comes after a fall from a significant height, or the mechanism of injury is significant, such as say a patient is knocked down by a vehicle, a high vehicle which is going at high speed. First thing is you must tell that you must approach the patient with the ATLS approach and manage the patient like that. But specifically you must concentrate on the cervical spine in this patient, and you should tell that you will approach the area with cervical spine control. Initially you can use manual inline stabilization. Manual inline stabilization. We control with manual inline stabilization probably first take. Then if there is a indication of intubation, you must have a low threshold to intubate a patient with cervical cord injury. because one thing is it will prevent aspiration. Second thing is you can improve the oxygenation and prevent secondary spinal cord injury. And like secondary brain injury, you can get secondary spinal cord injury. So because of that, you must make sure that the patient is oxygenated well. In addition, patients with spinal cord trauma can have other significant injuries in the face. And especially say a pedestrian is knocked down by a vehicle, then he is likely to have multiple injuries. For airway protection. Then during the airway, you had to mention about using succinylmethonium. Maybe after 48 to 72 hours, you can't use succinylmethonium. So after airway and cervical control, you can take off the manual insufflation and put hard cervical collar and put head blocks. It also, what are the breathing problems that you can get in a patient with cervical spine? Sorry, in a patient with spinal cord injury. The breathing problems and
Due to diaphragmatic paralysis and the mechanism of injury, there may be hemothorax, pneumothorax.
Oh, even specific, like if you think about the specific injuries in a patient with spinal cord injury due to the spinal cord injury itself, so though they can be associated in the case of polytrauma, you can have various injuries. Pneumothorax, tension pneumothorax, open pneumothorax, massive hemothorax.
Diaphragmatic paralysis due to cervical spine injury.
Breathing problems depends on the level of injury. So the diaphragm then C3 to C5 it was intercostal muscles then T8 to E to it was abdominal muscles then it was T8 so depending on the level of the spinal cord injury, you can anticipate breathing problems. Of course, you can have breathing problems due to other associated injuries, but specifically when you talk about spinal cord injuries, if the patient is having an injury above C3, then there will be diaphragmatic paralysis. C3 willing would have injury the patient can't breathe himself, and the patient will depend on ventilation long term. Say if the injury is between C3 to C5, then the patient, you can't exactly say whether the patient needs breathing assistance. Some patients will need, but a majority will need. Then if the injury is between C5 to T8, there will be loss of intercostal muscles. Then sometimes the patient might need ventilation in the short term. Then below T8, there will be loss of abdominal muscles. So breathing problems depends on the level of injury. There is another thing, I think, I don't know whether I have told about this. A patient with cervical spine injury, they will be comfortable in their breathing in the supine position rather than in the proper position. So if there is a cervical spine cord injury patient, don't go to prop them up. Prop them up or maintain a head tilt or whatever. Like they'll be more comfortable in the supine position. I don't know mechanism it was second. Cardiovascular system what are the problems? Then the patient can have waist dilation waist dilatation saha bradycardia and pulluwan because of the sympathetic involvement you should not like over enthusiastically pump fluid if a patient is having neurogenic shock and if the patient is hypotensive, because the fluid overload can have various consequences. It's not like pumping fluid to a patient with septic shock. Neurogenic shock can fluid then because of that you should have a low threshold to start vasopressors, especially NORAD. It was a main concern. It was you should not do certain procedures which stimulate the patient. Like if you do something, say example, if you do catheterization or say you do a wound toilet or something like that, because of stimulation there can be vagal activity, and because of the sympathetic unopposed vagal activity, because already the sympathetic outflow is gone, the patient can get severe bradycardia and even the patient can die. So if you do something to a spinal cord injury patient, always make sure you have some atropine. In case the patient has bradycardia, you can give atropine. හරිනේ. ඊට පස්සේ what are the other important considerations in the patient with spinal cord injury? අර ඔයගොල්ලෝ මේ ප්‍රශ්නයක් අහලා long term and short term effects කියන්නේ කියලා. මොනවද other important considerations? short term මේ මොනවද?
DVT prophylaxis.
DVT and PE දෙකම වෙන්න පුළුවන් නේ because of immobilization ඒක කරන්න ඕනේ. Then you have to have measures for gut protection. ඇයි ඒ? Because of unopposed vagal tone, they can have increased acidity. හරිනේ ඒක නිසා you have to give stress ulcer prophylaxis. And then you have to start early enteral nutrition. Cutting ගන්න බැරි නම් whatever the method, you have to start them on nutrition. හරිනේ. ඊට පස්සේ the patients might need prokinetics because of unopposed vagal activity. There can be gastroparesis. හරිනේ ඒක නිසා might need prokinetics, and because of gastroparesis the patient can develop nausea, vomiting. So antiemetics දෙන්නත් ඕන මේ සමහරවිට. Then you have to think about pressure areas. Pressure source develop වෙන්න පුළුවන් නේ. හරිනේ. ඊට පස්සේ the patients can have sometimes pain. ඒකට treat කරනවා. neuropathic pain එක develop වෙන්න පුළුවන්. Then you have to think about the psychosocial issues as well. හරි ඔක්කොමනේ. ඒක තමයි in a nutshell. ඊට පස්සේ you have to know about this various syndromes. Syndromes ටික දන්නවද? anterior spinal artery syndrome එක anterior 3 ගියොත් එහෙම. Then you have the Brown Sequard syndrome if there's any section. ඊට පස්සේ cauda equine එන්න පුළුවන්. Central cord syndrome and posterior cord syndrome. ඔය තමයි main ටික. ඒ ටික දන්නවද බලන්න. medicine වලත් කරනවනේ neurology වලට. මේ ප්‍රශ්නයක් තියෙන ප්‍රශ්නෙත් එක්ක බලමු. මේක. මේ තියෙන regarding the assessment of a patient with cervical spinal cord injury, all of the following statements are true except make it. In a source to read about neurogenic and spinal shock to not clear today's lesson. Might make a presentation and send to you. Mace. Man දාන්න presentation එක හදලා ඉවන්න. ඔව් පොතක් කියවන ගියොත් එහෙම පා වෙනවා. මම I'll make a presentation and send to you all so that you can go through it. ඒක ඇත්තටම වන්න බොරුවට නෙවෙයි කිව්වේ ඇත්තටම වන්න. මේකට උත්තර කියන්න බලන්න. Go.
B.
B. When come back. වෙනුර උත්තර කියන්න බලන්න මේක. ඒ
in central cord syndromes, upper limbs are affected more than lower limbs. So it is true. If the injury is at C4 level, then diaphragm is most probably intact, so the breathing pattern can be abdominal. And I'm not sure about the D, but but indeed there could be asystolic cardiac arrest, as there is sinus bradycardia, which can be severe, and but during tracheal suctioning, it
It's
could lead
true.
to autonomic dysreflexia. So it's probably C. I'm not sure.
It was second. Okay, I'll take central cord. What is central cord syndrome? Central cord syndrome කියලා දන්නවද? So in central cord syndrome, you can get central cord syndrome due to bleeding, infarction or edema involving the central gray matter of the spinal cord. It is usually seen in the cervical cord. So because of that, in the central cord syndrome, what you can see is here the in the spinal cord, we think that the nerves responsible for the upper limb travel centrally and the lower limb travel peripherally. So because of if there is central cord syndrome, there will be arm weakness, which is more prominent than leg weakness. So because of that, first one is true. In central cord syndrome, arm weakness is more than leg weakness. Reason is the nerves responsible for the upper limb travel more medially, whereas nerves responsible for the lower limbs move peripherally. It was a breathing pattern is mainly abdominal if cord injury is at C4 level. ඒ කාරණේ intercostally මේක ගිහිල්ලා ඒකට බඩින් තමයි එන්නේ. Hypoxia is uncommon during the early ED state. ඒ කියන්නේ මොකද්ද? In a patient with cervical cord injury, hypoxia is very common. Because of what? Because of the main muscles are gone. It was second. Asystolic cardiac arrest is relatively common following tracheal suctioning. So I told that in cervical in injuries involving above T6 or maybe T5, there will be loss of sympathetic tone to the sympathetic innervation to the cardiac muscles, and there will be predominance of the vagal fibers. Because of that, with very small stimulations, there can be increased vagal tone, and patient can have a severe bradycardia that can lead to cardiac arrest. හරිද? ඒක තමයි ඒක. හරි? ඊළඟ එක.
Sir, can you explain the last one again? Asystolic cardiac arrest is relatively common.
Okay. So in patients with spinal cord injury, so when you consider the innervation to the cardiovascular, autonomic innervation to the cardiovascular system, you have the sympathetic and parasympathetic, right? To the heart, you have the sympathetic and parasympathetic. So for the heart, you get the autonomic innervation from the sympathetic. You have these sympathetic trunks on either side of the. Usually T2 to T5 will in. If the injuries between those areas, there will be loss. Like either the sympathetic innervation will be weak or will be lost. So because of that, there will be the innervation predominantly vagal. Oh, even with the minor stimulations, like one of the commonest things which will cause bradycardia and maybe arrest is tracheal suctioning because of the vagal stimulation. හරිනේ?
Okay, sir. Thank you.
ඒක නිසා ඇට්‍රොපින් එකක් තියාගෙන කරන්න ඕනේ. අතේ තියාගෙන. මේ මෙඩික් බලන්න දැන් ටක් මේක පේනවද? cervical spine injuries පේනවද ඒක?
පේනවා සර්.
ඒක cervical spine injuries represent more than one half of all spinal column injuries. What additional injuries are commonly associated with cervical fractures? මේ මොකක්ද? ඔක්කොම බලන්න උත්තරය. cervical spine injury එක කොහෙද එන්නේ? සමහර උඩනේ. උත්තරේ තමයි මේක brain injury and additional spinal fractures. 25% of all spinal injuries have at least a mild form of brain injury, and 10% of patients with cervical fracture will have another non-congenital spinal fracture. Alright? It means always, if a patient comes with a cervical spine injury, unless the patient is conscious, you have to think about a brain injury and other fractures in the spinal cord or injury to the spinal cord. Alright? ඊළඟ එක මේක neurogenic shock is associated with what level of spinal cord injury and causes systemic hypertension? What mechanism? මේක අර neurogenic shock and spinal shock එක තේරුම් නැහැ කියලා කෙනෙක් කියලා තිබුණා. neurogenic shock කියන්නේ it's the shock secondary to peripheral sympathetic denervation, especially when there is cord injury at cervical or thoracic levels. If a patient has a spinal cord injury in the lumbar region, they will not get neurogenic shock. ස්පයිනල් මොකක්ද සිම්පතටික් එක තියෙන්නේ ලම්බ එකේ නෑ තොරසික් උඩනේ තියෙන්නේ හරිද? And the patient will present with hypertension, bradycardia and hypothermia because of loss of heat. හරිද? ස්පයිනල් ෂොක් කියන්නේ So spinal shock කියන්නේ it like in simple terms it refers to the flaccidity and loss of reflexes that occur immediately after spinal cord injury. හරිද? එතකොට spinal shock තියෙන එක්කෙනෙක්ගේ neurogenic shock තියෙන්න පුළුවන්. But spinal shock කියන්නේ neurogenic shock නෙවෙයි. Spinal shock කියන්නේ the you describe you it's what do you call so reflexes and flaccidity immediately after spinal cord injury. Alright, it's sort of a phenomenon you describe. So in a patient can have neurogenic shock and spinal shock both. The clinical characteristic feature of spinal shock is it's just the patient is in the acute phase the patient is flaccid and doesn't have reflexes. And in the long run, the patient develops spasticity and increased reflexes. හරිද ඒක? මේ කෙනෙක් තේරුම් නැහැ කියලා තියුණා. neurogenic shock කියන්නේ blood pressure අඩු වෙන එකයි, bradycardia වෙන එකයි. spinal shock කියන්නේ spinal cord injury එක නිසා spinal cord එකේ shock එකට යනවා. එහෙම හිතා ගන්නකො. spinal shock එක නිසා spinal shock කියන එක don't think that it's a kind of a shock. like අපේ shock ටික දන්නවනේ distributive, obstructive, cardiogenic ඊට පස්සේ සම්බන්ධ මතකත් නෑ. හරිනේ? spinal shock කියන්නේ it's not kind of shock. You just assume that the spinal cord has gone into shock. spinal cord එකට පොල්ලෙන් ගහම spinal cord එක නිකන් අන්දමන්ද වෙලා යනවනේ. එතකොට පල්ලෙහාට පරණ තියෙනවා reflexes යනවා. ඒ වගේ.
Can spinal shock cause neurogenic shock?
In a spinal shock, in a patient with spinal shock, you can get neurogenic shock. Say if you get spinal shock in a patient with the lumbar spinal cord injury, then the patient gets an injury to the lumbar spine කියලා. හරිද? Still the patient can have spinal shock because at say the patient's sensory the level of the injury is L2, so below L2 there will be loss of muscle power and loss of reflexes. But in that patient there won't be neurogenic shock. For the same patient, say there's a cervical spinal cord injury. C3 there will be loss of reflexes and loss of muscle power. Plus, the patient will have neurogenic shock because of the vasodilatation. You just use the term spinal shock to describe the phenomenon where the patient loses reflexes and loses power below the particular level of the lesion. That's it. And neurogenic shock is something else. It is due to the loss of vasomotor tone due to sympathetic denervation. හරිද?
හරි සර්. Thank you.
මේ අර ප්‍රශ්නයක් මේ නම නැති SS කියලා කියන ප්‍රශ්නයක් අහලා තියෙන නම නැහැ. මේකේ උත්තරය මොකක්ද එතකොට? neurogenic shock acquired mechanism. හරියට T6 and higher distributed shock. දැන් spinal shock කියන්නේ අර shock කියන්නේ සාමාන්‍යයෙන් it's a state where there is inadequate circulation for tissue perfusion, isn't it? But spinal shock is not a kind of circulatory inadequacy. It's something related to the spinal cord. හරිද? I hope it's clear. So neurogenic shock again after the injury, if the injury is at the thoracic level or cervical level, sympathetic nerve trunks දෙක යන්නේ අර cerebral column එක දෙපැත්තේ. ඒවටම ඔක්කොර ඒව ගියොත් තමයි යන්නේ. ඒ sympathetic outflow එක දෙන්නේ spinal cord එකෙන්නේ. මතකනේ ඒකනේ. spinal cord එකෙන් ගිහිල්ලා sympathetic fibers අර මේවයි මොකද්ද මේ ganglia වල synapse වල ඊට පස්සේනේ යන්නේ distribute වෙන්නේ. සාමාන්‍යයෙන් neurogenic shock spinal shock එකේ අර මේ reflexes වැඩි වෙන්නේ after usually about 3 to 6 weeks. ඒක හරියටම මතක නැහැ සාමාන්‍යයෙන් එන්නේ after 3 to 6 weeks. හරිනේ neurogenic shock can occur immediately. Spinal shock එකේ phases එක තමයි වෙනස් වෙන්නේ depending on the time period. I hope it's clear. මේක ඊළඟ එක මේ තේරුණාද මන් දන්නේ ඇසිටි වෙන විදිහ කියන්න පුළුවන්ද කියලා අහනවා කවුරුද දන්නවද මතකද ඒක අහලා තියෙන කවුරු හරි ප්‍රශ්නයක් අහලා තියෙනවා ස්පයිනල් කෝඩ් ඉන්ජරි එකේ ෆ්ලැක්සිඩ් ස්පැස්ටික් එන විදිහ කියන්නේ කියලා एक पास කියන්න මේක ඊළඟ එක spinal cord injuries can be defined by neurologic level and severity in addition to associated syndromes and morphology. Which of the following describes a brown sequard syndrome at T5? brown sequard එකේ මොකක්ද වෙන්නේ?
Section of the cord.
hemisection of the cord නේ. so මේ හරිනේ කවුරුත් දන්නවද hemisection of the cord කියලා මතක ඇතිනේ. hemisection cord આવත් එහෙම මොකද මේකෙන් එන්න පුළුවන් hemisection of cord මොකේද?
Contralateral motor function restrict.
complete complete තුන out නේ complete දෙක spinal cord එක දෙකට පැති කපලා ගිහිල්ලා. ඒකට complete දෙක out. ඉතුරු වෙන්නේ partial penetrating වෙයි මේක. partial spinal cord abnormality with reduced abnormality. ඒ දෙකෙන් මොකේද දෙන්නේ? ඒකනේ සාමාන්‍යයෙන් penetrating injury එකක් ආවම මේ පැත්තම යන්න පුළුවන් නේ හරිනේ so the answer is a explanation එක දාලා තියෙනවා brown sequard syndrome is often caused by a penetrating injury in which the spinal cord is injured on one side results in ipsilateral motor loss from injury to the spinal thalamic tract loss of sense of position from injury to the dorsal column and loss of pain sensation to the contralateral side 2 levels below the injury site ඒකේ නැටි මතකයිනේ dorsal column එකයි corticospinal tracts උඩින් මේ cross කරන්නේ. හැබැයි spinal thalamic එක level දෙකක් උඩට ගිහිල්ලා cross කරන්නේ නේ. ඒකයි හේතුව. හරිනේ? ඊට පස්සේ එක මේක a patient with a non-cervical spine fracture who is being transferred from a rural hospital to definitive care should be transported in which way? මොකද උත්තරේ? කො මේක මොකද්ද? So basically what you should do is you should immobilize the head and the cervical spine. I don't know, you could use a collar and then you could put head blocks on either side. Collar එක නැත්තම් අර දන්නවනේ හදන හැටි. දන්නවද ඒක හදන හැටි? cardboard වලින් හදලා ghost ටිකක් වටේ දාලා ඊට පස්සේ sand bag දෙකක් ඔළුවට දෙපැත්ත තියලා straps දාලා ගන්න ඕනේ. So transfer is semi-rigid collar head restraint. right? මේක patients with cervical fractures above C6 require special consideration prior to transportation due to go. මොකද උත්තරේ නේද? Patient with cervical fractures above C6 are potential progression respiratory failure. ඒක තමයි main concern එක. Because of cervical spine injury, they can go to respiratory failure, so you have to secure the airway. ඊට පස්සේ ටිකක් කම දෙන්නක් ගාලා. මේක පේනවද?
පේනවා සර්.
මේක උත්තරේ කියන්න. 68-year-old patient was brought back to the ward following an uncomplicated abdominal aortic aneurysm repair. He developed significant pain post-op. He was seen by the anesthetic team 15 minutes ago and an epidural top-up was given. Nurse calls you to review as blood pressure of 90/50 and pulse rate of 60. Dizzy, he feels dizzy but not in pain. We most likely diagnosis of this patient. කියන්න බලන්න.
P.
මොකද්ද?
C is the
C නේ අයියේ. Why not cardiogenic shock? Say a patient who has undergone abdominal aortic aneurysm repair develops hypertension. Forget about this one. On ප්‍රශ්නයක් එනවා මේ Esophageal surgery. The same patient, 60-year-old patient was brought back to the ward following an uncomplicated. It was say he has given epidural and blood pressure is 90/50. What can be? What can the cause? Maybe two causes. What is special about patients with abdominal aortic aneurysms who have undergone repair? ඒගොල්ල vascular patch ලානේ. Those patients have like high risk factors for cardiovascular, very like long, multiple risk factors for cardiovascular diseases. ගොඩක් smokers ලානේ. So they are smokers plus vascular patch. So in the post-op period, if a patient develops chest pain or drops the blood pressure, you have to have a high threshold to exclude an acute coronary event. I don't know, you must like in this case scenario, it's very clear that the patient developed pain, got an epidural, and because of that the blood pressure dropped because of the sympathetic blockade. But still, in a patient who develops blood post-operative hypotension, you should think about other causes as well. You should not have tunnel vision. There are high blood pressure samanai what cardiac output into peripheral vascular resistance. So it could be either a problem with the cardiac output, either due to problem in the preload, afterload, or contractility, or due to a problem in the SVR, mainly due to vasodilatation. So this patient can develop to post-op MI very easily. I have seen like a number of patients, even young patients who are 35, 40, who has died because of myocardial infarctions or acute coronary events, especially after major vascular surgeries. So when we become HO, make sure if a pain or drops blood pressure, please do ECG and exclude an acute coronary event. These patients can have diabetes as well. So because of that, they can easily get silent MIs. You can have a very low threshold to do ECG if a patient develops hypertension or chest pain post-operatively, especially in patients with multiple cardiovascular risk factors. It was you should wonder whether this is bleeding. So what are the causes which are against bleeding? දැන් මේකේ එපිඩුල් එක ගහපු ගමන් blood pressure අඩු වුණා ඒක තමයි උත්තරේ කියලා අනිත් ඒවා නිකන් අතරලා දාන්න එපා. That's how you should do MCQs. හරිනේ? What are the causes which doesn't favor that the patient is bleeding?
Pulse rate.
Pulse rate නේ. So earliest one is class 1 2 3 4 hemorrhage කියලා කරේ. Class 1 එකේ it's like giving blood to somebody, giving 1 point. So class 2 you get increased blood pressure, increased heart rate and narrowed pulse pressure නේ. ඒක නිසා pulse rate එක 60 ඒක නිසා 1 වෙන්න පුළුවන්. තව මොකද්ද pulse rate එක ආවනවද? Beating against ඉන්නේ. ඒ දැන් urine output is adequate නේ. ආවනවද? CVP 12. What does this mean? CVP is 12. Does it mean anything or does it mean something or nothing? So at teaching hospital Karapetia, this will be taken as something which represents adequate volume status, but that's not the case. CVP12 is just a number. It doesn't mean anything. It just reflects that CVP is 12. That's it. And then you all take it in any way you want, because some surgeons or VPs, they will ask what is CVP, what's the importance of it, what's the normal range, what does it tell, etc. CVP is something which reflects the right heart pressure, that's it. Neither is trend or absolute value, doesn't tell anything about the fluid status nor fluid responsiveness, that's it. PE එකෙන් බලන්න. Unlikely soon after surgery. Sepsis. Ekat unlikely soon after surgery. So what are the other complications you can anticipate after a repair of abdominal aortic aneurysm? දන්නවද? දැකලා තියෙනවද aneurysm මේ ඔයගොල්ලන්ගේ ප්‍රේතය හොඳින් මම හදපු එක නෙවෙයි. මේ ප්‍රශ්නේ අහුවොත් 68-year-old patient comes back to the ward following an uncomplicated abdominal aortic aneurysm repair. The following are the early complications that you could anticipate in this patient. A. Paraplegia. Following 24 hours after surgery. A. Paraplegia. 2. Renal failure. 3. MI. 4. ileus. 5. Abdominal compartment syndrome. මොනවද දෙන්න පුළුවන්? එහෙනවද කියන්නේ? හලෝ.
එහෙනස්.
මේ මොනවද දෙන්න පුළුවන්? MI හරිනේ. ඒක තමයි මම කියපු ඔක්කොම complications. Patients can develop MI or non-ST elevation MI or unstable angina, whatever it is, acute coronary syndrome. They can develop renal failure, especially in infrarenal abdominal aortic aneurysms. When you repair the abdominal aortic aneurysm, you clamp the aorta. හරිනේ aorta clamp කරාම aorta එකෙන් පල්ලෙහා blood supply cut off වෙනවා. ඒක නිසා දැන් අර abdominal aorta clamp කරලා පල්ලෙහා ටික repair කරනකම් ඒ කියන්නේ මේ perfusion නැති කාලයක් එනවා. හරිනේ. ඒක නිසා especially if it's an infrarenal one, the patient can get renal failure. ඒ infrarenal තිබුණොත් එහෙම renal එක පල්ලෙහාට යනකම් clamp කරනවා abdomen මේක. તો renal blood supply නැති වෙනවා. හරි. ඊට පස්සේ you can get paraplegia because of spinal cord hypoperfusion. හරිද? then ileus කියවනේ ileus එන්නේ sympathetic මේව එන්න හින්දෙන් පුළුවන්. මොකද්ද මේ electrical disturbances හින්දා. abdominal compartment syndrome කියලා එකක් දන්නවද? abdominal compartment syndrome is something you get because of increased intra-abdominal pressure. Especially when you do laparotomies, you can get it. හැම laparotomy එකෙන් නෑ. දැන් laparotomy එක කළා බඩවැල් ටික ඇතුළට දානවා ටයික්ලෝෂියා කරනොත් එහෙම ඒ වගේ වෙන්නේ. So those are all early complications. You can sometimes get complications due to massive transfusion because abdominal aortic aneurysm repair can be associated with massive transfusion. And then you can get renal failure, MI, paraplegia, then abdominal compartment syndrome, ileus. Then you can get embolization. සමහරවිට aorta එකේ තියෙන fat it can embolize and cause effects in the distal the peripheries, especially in the foot. හරි ඒ ප්‍රශ්නේ ඉච්චර ඊට පස්සේ මේ ඔයගොල්ලෝ ප්‍රශ්නයක් මම ඒ ගැන කතා වටේත් පොඩ්ඩක් කිව්වා ඊට පස්සේ මේක top ලොකුමුඩි ගන්න 50-year-old lady post-op 5th day of rectal surgery found to have high fever CA 101 and WBC count 10,000. Ultrasound scan shows a pelvic abscess. Ultrasound guided aspiration done completely and sent for culture and ABST. Prophylactic antibiotic cefuroxime and metronidazole started. 3 days later, the ABST pattern shows resistance to cefuroxime and sensitive to cefotaxime, amikacin gent. Now the fever is between 98, 99 and WBC count is 30,000. Which of the following is appropriate? මොකද කරන්නේ? C. Cefuroxime to cefotaxime. මොකද කරන්නේ? ඒක obviously නේ. cefuroxime resistance එකට දෙන එක තේරුමක් නැහැ නේ. So we have to change the antibiotic නේ. හරිනේ ඒක? හරිනේ නේ?
Excuse me sir, मैं respond කරලා තියෙන නිසා මේ antibiotic එක continue කරන්න බෑද? In vitro in vivo antibiotics වලට response එක වෙනස් නේද?
එහෙම එකක් තියෙන නමුත් ඒක cefuroxime වලට දෙන්නේ ඒක මේ 3 days later නේ. හැබැයි තාම ඉතින් මේවා high නේ. The fever is between WBC count is still high නේ. මම ඒක ඔන්න හොයලා කියන්න. මට in vitro එකයි දෙකේ හැම ඇන්ටිබයොටික් එකම එක අදාළ වෙන්නේ නැහැ. එහෙම එකක් තියෙනවා. ඕක ආයෙ හරි ඇහුවද ඕක? ඕක ඇහුවද කාගෙන් හරි?
No sir.
මම දන්නවා in vivo කතාව මේ ඒක හැම ඇන්ටිබයොටික් එකම applicable නෑ නේ. දැන් මේකේ තියෙන 5th of day TDS data තාම ඉතින් මේක high නේ respond කරලා now the fever is CI WB6 මේකයි හොඳටම respond කරයි කියන්න බෑනේ නේ තාම fever spikes තියෙනවා WB තාම high නේ මම පොඩ්ඩක් ආයෙත් හොයලා කියන්න හොඳද ඔව් මයික්‍රෝ එකනේ අහලා කියන්න ඊළඟ එක එන්නේ මේක පේනවද? ඔගොල්ලෝ ඇතිනම් කියන්න නවත්තමු. මටද මේ වතුර ගිහලා කරන් පුළුවන් මට කම්මැලි නෑ. මේක ඇතිනම් මේක දැන් ලියන්න ඇති කියලා. මේ ස්ක්‍රීන් එකේ මේක 65 year old patient with COPD is treated for right low volume cellulitis. He develops difficulty breathing, saturation 88, requires autotherapy, which is the most of ඔන්න උත්තරේ ටොක් ගාලා කියලා යන්න පුළුවන් නැත්නම් ඔය ගැන කියලා දෙන්න පුළුවන්. මේක obviously නේ COPD එකගේ ඔක්සිජන් දෙන්න ඕනේ කියලා 28 වලින් ඔක්සිජන් දෙන්න ඕනද? saturation 88 කියමු. ඔන්න යා. එතකොට දෙනවද? What would be the saturation target that you would aim for? 88 92 කියලා දන්නවනේ දන්නවද? I hope you all know that. So in a patient with COPD, one thing is if the patient is you have to give the lowest possible amount of oxygen. And so best thing is to give via venturi mask, then we know as to what's the amount of oxygen we are giving. So when would you start non-invasive ventilation for a patient with COPD? Say this same patient here, 65-year-old patient with COPD, right lower cellulitis, difficulty in breathing, respiratory is 30, and SATs are 85. Which of the following are indications to start non-invasive ventilation? Following එක PO2 of 60, දෙවැනි එක CO2 of 70, තුන්වෙනි එක pH of less than 7.35, හතරවෙනි එක SATs of 90, පස්වෙනි එක SATs of 85. මොකද්ද? When would you start non-invasive ventilation for a patient with COPD? That's the question. मैं मेक कल नवाते मोदे नत्तम में बोल ले पाए टगल किया मैं कटिंग किया बैठे था मैं मेक लिया ना तू
When the patient has severe respiratory acidosis and if the patient is exhausted,
severe respiratory acidosis bad, there should be a value. Severe kiwama, it can be 7.1, it can be 6.9, it can be 7.2, it can be 7.3. What do you mean by severe?
pH less than 7.2.
No, usually the British Thoracic Society guideline එකේ තියෙන්නේ to start non-invasive ventilation for patient with COPD, the pH is 7.35. නිකන් අපිට නිකන් කිව්වම නිකන් හිනත් යනවනේ ඒක. But that's the target they have recommended. If the pH is less than 7.35, හරිද? Or if the PCO2 is more than 66.5 kilopascal. ඒ කියන්නේ roughly 7.5 into 6.5 වගේ. 45ක් විතරනේ. ඒක මේකල් නවත්තන බයන්න මේ ඊට පස්සේ දවසේ කම්ම කියලා තියෙන. හරිද? ඒක තමයි indications. There are basically 3 indications. පොතේ තියෙන textbook indications are if the pH is less than 7.35, PCA2 is more than 6.5 kilopascals, or make roughly millimeters में अगर क्या at least 5 वगे, or if the respiratory rate is more than 23. But you should not always depend like strictly adhere to the guideline. You should apply the knowledge you have gained to the patient in front of you, or individualize කරන්න ඕනේ. ඒක තමයි rough ඒවා. So what sort of non-invasive ventilation is preferred for patients with COPD? Is it BiPAP or CPAP, or tube in the patient? මේකල නවත්තන අග්ගල් කියන්නේ
BiPAP sir.
ඇයි BiPAP? Why not CPAP?
Because there's type 2 respiratory failure in COPD patient.
Okay, so what's the advantage of giving BiPAP or CPAP? Why do you give BiPAP for a patient with type 2 respiratory failure? Why not CPAP? BiPAP, CPAP, වෙනස දන්නවද? CPAP කියනකොට you just elevate the baseline pressure and prevent collapse of alveoli. So what you do is you improve oxygenation. At end expiration you prevent the alveoli and you keep the alveoli open. A spin එකක් දානවා වගේ. So if you want to apply CPAP, you basically put to improve oxygenation. හරිද? But in case of BiPAP, in addition to the CPAP or PEEP, you give another support during inspiration. හරිද? Inspiration එකේ දෙන support එක නිසා the patient's tidal volume will be increased. සාමාන්‍යයෙන් හුස්ම ගන්න එක්කෙනෙක්ගේ හුස්ම ගන්න එක detect කරලා machine එකකින් තව අමතර pressure එකක් දෙනවා to augment the ventilation or tidal volume. හරිනේ? If there's a problem in the carbon dioxide, it's always due to problem in the ventilation. So because of that, you have to assist the inspiration and increase the tidal volume, and because of that, there will be much more CO2 clearance. But in case of hypoxia, you just put the CPAP. But nowadays, you don't usually give CPAP alone for patients. You combine always it with the pressure support. So you make it BiPAP. In simpler terms, what you do in BiPAP is, in addition to the PEEP, you give an additional support to the patient during inspiration, so that the tidal volume will be increased and the patient will get ventilator support, and it will help with the CO2 clearance. And that's why you give BiPAP in type 2 respiratory failure, because there's a problem with CO2 clearance, plus the patient is hypoxic. Alright? Not the one. වෙන ප්‍රශ්න තියෙනවද මේ අදට කරපු ටිකේ? මේ ගොඩක් හදන්නා ප්‍රශ්න පෙන්නන්න මේ මේ MCU හදන්නාවා 50ක් විතර. 79ක් හදන්න. වෙන අහන්න තියෙනවා අහන්න. Can you discuss essays regarding trauma? Sure. Can you send the MCQs prior? I'll send. Mom make one namme adappu එක. So we can read around and be ready. Okay, sure. Essays regarding trauma කරන්න පුළුවන්. So this will be more productive. ඉතින් කිව්වනේ නේ කිව්වනම් MCQ හදලා ඉවරනවා. මේ දැන් මේ මේක දාන්නේ. මේක එවන්නම් මේ හදපු එක. So we can do it whenever you guys want again. Hurry or not,
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
No problem.
Thank you, sir.
BiPAP COPD use කරන්නේ තේරුම් නැතිලු. So COPD patient ළඟ වෙන්නේ there is a problem with oxygenation plus problem with ventilation. හරිද? මේ Samsung COPD කෙනාගේ වෙන්නේ කාබන් ඩයොක්සයිඩ් ටික මේ තා ප්‍රශ්න දෙකක් තියෙනවා මේ Samsung ට කියන්නේ මේ COPD කෙනාගේ the patient කාබන් ඩයොක්සයිඩ් ක්ලියර් කරගන්න බෑනේ ඒක තමයි main problem එක කාබන් ඩයොක්සයිඩ් ක්ලියර් කරගන්න බැරි ඇයි එක්ස්පිරේෂන් එකේ බ්‍රොන්කෝ කන්ස්ට්‍රික්ට් වෙනවනේ ඒක නිසා එක්ස්පිරේෂන් එක තමයි අප්සෙට් ගහන්නේ. හරිනේ? ඉන්ස්පිරේෂන් එකේ බ්‍රොන්ක්ස් ස්පැසම් එන්න පුළුවන්. ඒක නිසා කාබන් ඩයොක්සයිඩ් රිටෙන්ෂන් වෙනවා. හරිද? The carbon dioxide retention වෙන්නේ because of a problem in the ventilation. So unless we support the ventilation, we won't be able to clear off the CO2. හරිද? BiPAP කියන්නේ නිකම්ම නම පොඩ්ඩ සැර විතරයි. BiPAP එකේ වෙන්නේ PEEP එකක් දෙනවා. PEEP එකක් දීලා at the end of expiration you prevent alveoli collapsing. ඊට පස්සේ pressure support එකක් දීලා ඒ pressure support කියන්නේ inspiration එකේ support එකක් දෙනවා. ඒකෙන් ventilation tidal volume එක වැඩි කරලා ventilation වැඩි කරනවා. ඒක නිසා ventilation වැඩි කරන එකෙන් carbon dioxide clear වෙනවා. PEEP එකෙන් oxygenation improve වෙනවා. ඒකයි BiPAP දෙන්නේ COPD වල. හරිද? Samsung. හරි නැත්තම් කියන්න. BiPAP යමුනා. BiPAP CPAP ආයෙත් කියලා දෙන්නකෝ. හරිද? Grace. ඊට පස්සේ වජිත් cervical spinal level එකයි respiratory paralysis වෙන විදිය ටිකක් කියන්නකෝ. දැන් cervical cord එක ගත්තම mainly කැලි මේ RPS මොකද්ද breathing abnormalities ගැන කතා කරනකොට කැලි තුනයි කතා කරන්නේ. එකක් තමයි cervical එකේ ගියොත් එහෙම අනිත් කැලි දෙකයි. එකක් cervical ගියොත් එහෙම අනිත් thoracic ගියොත් එහෙම. හරිද? දැන් C3 වලට උඩින් ගත්තොත් එහෙම diaphragm එක කෙලින් paralyze වෙනවනේ. හරිනේ වජිත්. ඒක නිසා patient can't breathe on his own. C3 ගියා කියන්නේ patient ඉන්න තාක්කල් මේ heart එක ගහනකල් සහ ඔලේ තියනකල් patient dependent on the ventilator. You have to support the ventilation. Diaphragm එක ගියා කියන්නේ තනියෙන් breathe කරන්න බෑ. ඊට පස්සේ C3 C5 අතර injury එකක් තිබුණොත් එහෙම සාමාන්‍යයෙන් diaphragm එකට තියෙන C3 C4 5 නේ. ඒක C3 C4 C5 level එකේ injury එකක් තිබුණොත් එහෙම අපිට කියන්න බෑ සම්පූර්ණයෙන්ම diaphragm එකේ ගියයි කියලා. දැන් C5 වලින් ගියොත් එහෙම sorry ඊට උඩටින් සප්ලයි කරන්න ඕනේ. C4 වලින් ගියොත් එහෙම C3 තියෙනවා. C3 උඩින් ගියොත් ඔක්කොම නැති වෙන්නේ. ඒක නිසා C3 C5 ගියොත් එහෙම නිකන් partial denervation එකක් වගේ diaphragm එකේ. හරිද? They will like some patients will not need support, but some patients will need support, but the majority will need support. Hurry. It has a T8 වලින් ගියොත් එහෙම T8 වලින් ගියොත් එහෙම there will be loss of intercostal and abdominal muscles. හරිනේ? Because of that some patients might need, some patients might not need. හරියටම කියන්න බෑ. But the patients will experience clearance of sputum because of the like respiratory muscles වලින් එන total contribution එක අඩු වෙන නිසා. හරි T8 වලින් ගියොත් එහෙම abdominal muscles විතරයි යන්නේ. හරි? හරිද දන්නේ?
Yes sir.
දැන් ඉවරද quarantine? කවද්ද ඉවර වෙන්නේ?
නෑ සර් තාම නෑ 16 වගේ second PCR එක කරනවා.
අදුල ඉන්නවද සනීපේ?
ඉන්න වගේ
කොහොම ඉන්නවද දන්නේ අර කස්සට වෙලා අදුලේ පණීත් දන්නෙත් නෑ ඔකෙන්නේ. හරි එල් ප්‍රශ්න තියෙනවද? What is the exact level of cord injury to have neurogenic shock? Usually about T6 or T5. Tadul fine. Like මම මේක එවන්න කාටද එවන්න මේක? මම මේ දසුන්ට එවන්නන්නේ. දසුන්ට එවුවොත් එහෙනම් දසුන්ට දාන්න පුළුවන් දෙන්න පුළුවන් අනික් කට්ටියට. මම දසුන්ට එවන්නම් මේක. ආයිත් පුළුවන් දවසක ඔයගොල්ලෝ කියන්න මේක ඊට පස්සේ. හරි නේද? Okay then see you all.
thank you sir.
Okay.